we'll now have our closing synthesis panel. So I'd like to invite Mrs. Stripling and Secretary Mercado to come back up, and Dr. Wogan. And while they're coming up, we have a couple special guests that I just want to quickly recognize for being here. They were part of the delegation that traveled with the Secretary from Puerto Rico, Catherine de la Cruz Duran, who is the Assistant Secretary of Planning, Development, and Federal Affairs. Um, you, she just stepped out? Okay. And then Jessica, Carolina, help me with the last name. Oh, your last name is, okay. Who is the Program Manager and Principal Investigator for Crisis Hurricane Supplement. Glad you could be here. And then, of course, Commander Carolina Luna Pinto. So now I'll turn it over to Dr. Wogan for our closing synthesis panel. Thank you.
Thank you. So the synthesis panel, we're going to open it up for questions. We also have a series of questions that we've come up with that we can answer. First, I just wanted to kind of summarize what we've heard this morning. I started with the framing talk, and now I want to pull together all the various pieces that we've heard. Initially, Dr. Liebert kicked us off this morning by stating that the purpose of the forum was to monitor CDC's progress in pursuing health equity. And she stated that some view health equity as an aspiration and others as an achievement of best possible health for all, and that CDC sits at the intersection between this aspiration and the action. So that really gave us a charge to think through what our responsibility is and how we can apply this to emergencies. And then Admiral Red talked about his quote, "The rising tide does not rise all ships," and that health equity really must be intentional and deliberate. And Mr. Stribling also stated the intentionality and the importance of that, and that in emergency response, we're going to reinforce our structural racism if we're not careful to be very intentional in the work that we do, because emergencies tend to magnify the inequities that exist. So we must use this health equity lens to assess our strategies, our policies, our programs. And then we heard from Dr. Rodriguez, who emphasized the importance of understanding the historical backgrounds of the communities that we're deployed to, understanding their government structure and their unique vulnerabilities and the strengths in that area, and how important it is to work within the community. As my colleague recently said, a quote that she heard recently at Morehouse is that you don't do change for people, you do change with people. And then we heard from Dr. Dodgen. He pointed out that we actually have a very specific mandate, HHS does, to protect at-risk populations. And he highlighted steps to resiliency, which included neighbor-to-neighbor resilience and how to facilitate helping behavior. And then in our final talk, Dr. Kuwabara talked about the importance of knowing one's own cultural influence and understanding that we bring to the table our own personal biases. And Julio talked about the training that will be available to deployers and hopefully to a broader CDC audience to address that. And so with that, I think that we can move on. Do we have the questions on here? No? Okay. So I'm going to start with a question, and anyone on the panel can answer that question. And then certainly if you all have questions, if you're not in front of a microphone, you can head to a microphone or use the one in front of you. So the question is, what are some barriers you've had to address when serving at-risk or vulnerable populations in public health emergencies? Anyone on the panel? Dr. Regis, I don't know if you wanted to talk about it. I know during the response with Puerto Rico, there was disenfranchised populations that had historically not had trust with the government, and maybe that was a barrier.
Yeah, I think that the most the problematic situation that we have is that we never thought that we are going to have a Category 5-4 hurricane. You never can be prepared for that because you cannot fight nature. You don't know what is going to happen. Also, the problem that Puerto Rico have was that before the hurricane, Puerto Rico was in a very bad economical constraint. We have a bad electrical grid that was totally inefficient, and and we know that if a natural disaster we arrive to Puerto Rico, that will be the first challenge that will have. But I think that to criticize and to say that we was not prepared, nobody's prepared for a natural disaster, because you don't have control of the nature. Only God have. So I think that the other thing that maybe we could be doing different is the coordination between the federal agencies. I think that that is something that have to be addressed. Like I mentioned before, we need a coordinator or inter agency director that know everything about the how FEMA work, HHF work, all of the federal agency, and maybe that is the it's going to be like a sort of the preparedness and response, and in that way that can coordinate more efficient the help in case of a natural disaster. I think that that is the lesson learned, and I hope that if you agree with what I said, maybe you can take that message to Washington and make it happen. I think that it's not only going to help Puerto Rico; it's going to help any other emergency around the nation. Around the nation. So I think that could be a good starting. Maybe they can that director can have help from different federal agencies that work together with him, and everybody knows what to do in a event of a natural disaster. Uh, because I think that the is going to eliminate the red taping that always occur between when you ask for help. Is going to make the response faster, and people can be prepared. They can also give seminars to different federal agencies to teach them how to react on a natural disaster. And let me tell you something: this is the natural disaster are going to happen. Each year this can happen, so we have to be prepared in order to know how to address the situation. But I think that the most important thing is to be prepared, everybody coordinated, and work as a team. I think that is the most important message that I can talk about it.
Let me hit a couple of things on there, because I was going to raise 3 points, and I think you hit the first one beautifully, which is that the structures we have are themselves a barrier. And my experience in the Virgin Islands was that there were 4 different coordination centers that were in play: the federal center, the official local emergency management center, the unofficial one that was like in the governor's house, that was the real locus of power, that was separate. And then Mike Bloomberg had one set up himself because he's a billionaire and he can do that. And there were these 4 centers that were separate from each other, all running separate cycles, all coordinating different things. And what that led to was, the second point I would make is the blindness of the response, our inability to see these issues because of the tunnel vision we have because of the urgency. And my argument would be, emergency management literature outside of health equity, and I could do a whole 20-minute rant on this, shows that adrenaline is a bad idea generally, right? That tunnel vision gets in your way. So the more that you can, now that we have these tools, the vulnerability indexes, the visualizations, the job is to hold leadership accountable for using them. I think that's make leadership less blind. That's the second thing. And the third thing I would raise is the other thing we've got to talk about is data. Because when we're going out there are assessments happening. Everybody and their brother and their sister are doing an assessment in the field, whether it's a Casper, whether it's the Red Cross knocking on doors, whether it's a FEMA assessment. But what's happening is some doors are getting knocked on 12 times and some doors are getting knocked on 0 times because it isn't unified. So if we had a way to have a unified shared data collection platform that everybody would agree to use, that all those assessments would come into one place, then we could target that entire universe of networked resources towards where the needs were. Nobody wants to do that because everybody wants to brag to their own funders, right? Hey, look at the mission we did. Hey, look at the good we did here. But as a result, there are these pockets of vulnerability that are invisible, left unhelped and dying because you're not networking all of these resources together. We have that technology now. If we could develop the political will to get it done. So I think the structures are in our way. We have this innate blindness, and then we don't have an integrated data collection mechanism.
Yo creo que la barrera más grande es la comunicación. And if anyone doesn't speak Spanish, I just said the biggest barrier is communication. I think frequently we do speak in different languages to each other in disasters. Everybody has their own lingo. It may not be an official language, but it's something. We all have a way of speaking, and I think, again, sort of that lack of self-awareness of our own culture and wherever we're coming from creates those barriers right off the bat, because we're not really bothering to explain. And if you've sat in an EOC, you know it's an alphabet soup, right? It is just acronym after acronym after acronym after acronym, and nobody tells you. If you have been invited, sorry, thank you. If you're a community-based organization and you're invited to the table and you finally sit there, and then the people just start talking in this gibberish of alphabets, that you have no idea what they're saying, how sincere of an invitation is that, first off? But how much are you going to be able to participate? So I think communication critical in terms of barriers. And I think the other thing, we've gone through a lot of the barriers already, so I don't want to repeat myself, but I think one of the things that we have to remember is disasters expose the fissures that already exist in our communities. Whoever's most vulnerable in a disaster, they're usually worse off. Where there are disparities in terms of how resources are allocated to different parts of the community, as well as to different programs that are designed to serve the community, all of those things emerge tenfold during a disaster. So I think one of the barriers is, as I think Mitch has been saying, the systems that have created some of our inequalities and some of our challenges are in many ways reinforced during the disaster, unintentionally, but nevertheless. So I think part of it is we have to be sort of aware that the same sort of inequalities are going to surface in a disaster, and we have to be extra conscious of the need to address those. And I think that's a barrier because, of course, we all come into the situation with our adrenaline packing and everything else, and we want to dive in and do what we've always done and what we've trained and exercised to do. And it's very difficult, I think, to step back and say, wait, there are systemic problems perhaps in our community, or at least not problems, but challenges that we need to be thinking about. And so I think that often is a barrier, that just the ability to step back and look at some of these larger issues.
Yeah, so I would echo everything that's already been said, and then add to that, to just sort of that idea of being able to empower our responders to be able to integrate a lot of the ideas that we're talking about here today and to carry those forward in our work in the Emergency Operations Center, as well as in the field and in our interactions with our partners and our colleagues on the ground. I think, to the comments earlier, that if we are able to begin these conversations now in a preparedness stance, so we are starting to shift our way of thinking and talking about and approaching response now, before we get into those moments of, almost panic and how are we going to handle this, it at least frames the conversation from a different place from day one. So I would say that that's our intention, as well as to really think about how do we empower our responders with the tools and the knowledge in order to be able to most effectively respond.
I just want to point out that part of this very innovative project of doing the cultural humility training is that it points out two things. One, from our office's perspective, we're very invested in supporting initiatives that increase processes that advance a diversity and inclusion consideration within the agency, right? So for our deployers, we want to create an environment that really builds their skills to not just with external partners, but with each other as team members. As was said earlier in a comment, that they can acknowledge the diversity contribution that's in the room of their peers who they're working with during a response. So this issue of cultural humility, while it's very apropos in the context of external partner engagement, it's also very critical when we work with each other as colleagues because of that alphabet soup of skills and perspectives and terminology. The other issue that it raises for us, uh, given that this is a new project, is that we understand in the office that there are new skills that we as CDCers need to have if we're going to advance a health equity approach. Um, it does mean that we have to do things differently. It may not mean that our roles change, but that the way in which we approach our roles change. And so that's going to require some discussion, some training, and some contemplation.
Thank you. So all of your responses dovetail nicely into a next question. You know that you have great leaders on the stage. When they talk about a barrier, they also talk about a solution, and we heard solutions from each of you. So just want to ask if you can share other examples of strategies or programs that have reduced social, economic, and health disparities to address the needs of at-risk populations and public health emergencies, and how you're able to achieve this. So we don't necessarily have to go down the line, but if anyone has anything they want to add to the previous question, it would be great to hear.
I'll buzz in. Okay, so the first one is, and I want to brag on CDC for this. I don't know where this idea came from, but of all of the federal agencies, the CDC idea of sending long-term assignees into these jurisdictions to coordinate recovery work who are CDC employees for years, I think is incredible. And I'm so proud of you guys. Whoever in CDC came up with that idea, made the decision, supported that to give some of your blood and treasure on a long-term basis into these places is meaningful, and it advances capacity in a real way. So I just want to thank wherever that came from. I just want to thank you as a person that sees the impact that that's had in those jurisdictions. So I think that's one. I think, and that the lesson there is long-term commitment. And I say that because for us, New York City, we deployed folks to Puerto Rico, we deployed folks to Virgin Islands, and then we're out, we're done. You know what I mean? And they call me still, my VI partners, a couple times. They've said, "Hey, you were here, you were great. Help us, come back." And I can't, right? I don't have that ability. And that is a violation of equity principles, right? Because I did not establish long-term partnerships. And that's not the way it should be. I would love for a long-term EMAC commitment. The two others I'm going to say are in Ebola, there were two things that we did that I think were helpful concretely. One is that City Hall did say, and I alluded to this, that we wanted to track travelers coming back from West Africa. And that mission was initially assigned to the to the NYPD's Missing Persons Bureau to make sure that they had a beat on these folks. And what that essentially meant was that NYPD would go around tracking a bunch of African-American men in a lot of the most vulnerable areas of the city. But initially, the health department was cowed by this because we're humble, right? And this goes, I think, to the definition of humility. And I think this is important because this has come up a lot today. The definition of humility from my Sunday school days, Stan, is that it is about understanding the unimportance of you personally. But that does not mean that you cannot fight like a tiger for your mission. And what I saw our commissioner do was go to the head of the NYPD and go to the highest levels of City Hall and say, we're not going to do it this way. You know what I mean? We're not going to make this a police operation, because if we're going to have to do this, we're going to do this in an unintrusive, partnering way with the community. And the third thing that we did in that response was that we had a doctor on our staff who was from West Africa, who had family connections in some of the Ebola outbreak areas. I didn't know that person. We brought that person into our incident command system. We anointed them. You are now part of our inner circle. And that person with our health equity staff coordinated outreach to the West African community. They didn't have ICS training. They didn't know from emergency response, but they knew that community. They had expertise in that community, and they very strategically designed outreach mechanisms that led to the EPIC frameworks, these kind of engagement frameworks we're using today. And that was a controversial decision, right? Because the commissioner didn't know that person, City Hall didn't know that person. But we gambled on it and it paid off. And I would encourage all responding agencies to do the same. Trust people. Just trust them. They know their communities. They're smart folks that work in public health. Give them power, decentralize your decision making, and it will pay off.
Just out of curiosity, how many state and local people do we actually have in the room, or is it pretty much all feds? Any state and local folks? Nuestros compañeros de Puerto Rico, okay, and Mitch, all right, okay, well, never mind. So I won't talk about a lot of the tools that we have, other than we do have some great tools for how to build coalitions and how to, integrate more diversity into your coalitions, etc. But let me give you another very, very specific example, because I think these concepts are challenging, right? We can't even agree on what cultural sensitivity is, what resilience is, what's the difference between cultural sensitivity and cultural competence, and we can't even agree on this, and it gets very big and very complicated. And I think sometimes we need to be better at making it simpler and more specific. So let me give you a specific example. We have these things called federal medical stations, which are kind of deployable, almost like a MASH unit, right? Like a hospital you can set up and you can, serve people. Let's say if you have someplace where your hospital's down, like in Puerto Rico, so you bring them in and you bring NDMS people, or we've got some great PHS officers in the room to staff it and to provide the medical services. So when the FMS's, Federal Medical Station, got to explain our acronyms, were first set up, nobody had thought about the fact that the aisles have to be wide enough to accommodate wheelchairs. So because I was the lead for at-risk individuals at the time, I just basically did a brief education for our people doing this. And okay, here's some basic minimal standards that you have to meet when you're setting up a temporary hospital facility that will allow it to accommodate everyone who's going to come in and need services. Also, we had to set up a policy for people who had service animals, right? Who had to, typically a guide dog, but it could be something else. Being able to say, okay, let's talk about the width of your aisle. Let's talk about what your policy is on service animals. What's your policy on where you're going to put the caregivers or next of kin who are still going to be wanting to visit every day? Where are you going to accommodate them? Being able to break it down into simple tasks that are doable, that you can literally, in the term of the width of an aisle, you can literally measure your progress, right? That was really helpful to people. And I think often we get sort of mired in these very complex concepts that none of us even really agree on the definitions for. And then we turn it over to emergency responders who tend to be very concrete, right? Because they have very specific tasks, and we expect them to figure out how to implement the stuff that we can't even figure out. So one thing I would just say is I think sometimes where we've had the most successes have been where we can be very specific and concrete on what it is we expect people to do. Because if you can turn it into a checklist, they'll do it. Emergency, first responders, the EMS folks, whatever. But we're not always so good at that. So I would say it's a success, but it's also something we could work on.
Okay, we'll move to our last question just because we're a little short on time. So this question is both for the panel and for anyone in the audience. We want to know, what are some takeaways from today's forum that you can apply to your work? Okay.
Great question. Thank you. I appreciate that because really I don't have a question for the panel. I do want to thank the organizers for putting this together. It's been a really interesting morning, and there's a lot of thoughts going on in my head. And thank you for the secretary and the delegation from Puerto Rico from being here, and our guests here also. We've talked a lot about the time crunch and the adrenaline and the cultural humility piece, and we've talked about a lot of this. I'm a person who thinks that words matter. So one thing that we've talked about, and we keep saying preparedness and response, when I think what we really mean is a broader picture. So we're not just talking about preparedness and response. Recovery, we know that's in there. But I think that we'll always need those things. I understand that. We need to have the ability to respond and recover and so on and so forth. But I do think that when we're having these conversations, what can the feds or the states do to support communities and individuals to have a better understanding of their actual circumstances and potential for being at risk? And I think this is part of what public health does. We had communications, this is a strong capability at CDC. We were able to convince many people that smoking cigarettes is bad because they understand what the risk is. We got people to wear a seatbelt, not we alone, but I mean, these are the communications and so forth. So if we're looking at this as sort of a prevention piece, or helping people understand what they can do to take protective actions, most people are not in this world that we are in. Most people do not think about this stuff until the thing is barreling down on them, or it just did. And then you spend a lot of time thinking about it. So how do we support people in understanding a little bit better about what their own risk profile might be, or what protective actions address those specific things that make them disproportionately affected potentially by the disasters? Is it a matter of, we talked about, neighbor to neighbor. So it's like a neighborhood watch like you do for, crime? Is it, more communications? I understand the need for having champions. Do we have more information and, courses in school from elementary school age up through college, just so people have some familiarity and sort of literacy around these topics, and maybe even specific to the community they live in? I don't know the exact answer, but I know that there are a lot of communities who are not engaged in this conversation. We can't necessarily reach all of them. But I just think that we should add this. Dan showed that RAND ladder for resilience, and at the bottom it said teaching individuals and families to prepare for and respond to. I would say, can we add avoid? Don't be in the place, or don't be in the circumstance where you'll be injured, where that hazard turns into a disaster. There's some things that we can do, and then we will inevitably respond and take care of folks who were not able to protect themselves adequately. So that's my 2 cents.
I want to make a comment about that. I think that sometimes the federal government miss some important detail, and is that most of the NGOs and non-profit organizations receive federal funds for prevention, for education, and all of that. So let's use it.
Yeah,
Let's
let's
go
add
to
this
them and
into our.
use it, because you are spending the federal money to those organizations, and they have when they receive that money, they have a commitment of prevention, information, go to the community and all of that.
Yeah.
And when I become aware about that, I am using it right now in Puerto Rico. I am hitting the using it in everything. If I have a problem that for prevention of information, I call them first.
Yeah.
It's our responsibility, but I use them as a partner.
Yeah.
You understand? Because I don't have all of the resources to do it alone.
Okay.
So, and let me give you an example. About 2 weeks ago, they came an organization that deal with HIV patients for and they give the medication, they run the clinic and all of that. You know what? The federal government give the money for the medicine, for everything. So you know what I'm going to do now? Maybe we are talking about to see if I can give all of my HIV clinics to them, and they run, and they can run the program completely. There are 13 states that are doing the same, and I save money, give better services, and I become a partner of that organization, and we join efforts for a better care of that type of population. That's what it's all about.
Dan, you and I have talked about this before. So
The only thing I would say is I do think the concept of disaster risk reduction, which is perhaps not as popular as it was a year or two ago, but I know there are folks at CDC obviously working on it as well. But if any of you are not familiar, just look up disaster risk reduction. There are some really nice materials, particularly out of the UN. Most countries in the world have sort of adopted it as a way to think differently about this whole concept, which is what you're saying, which is
we want to help people to avoid being in harm's way in the first place. And there are some things that you can do, right, that mitigate people's risk because, as we know, lower income communities, for example, are much more vulnerable in a hurricane or in an earthquake because the building standards are often different or not enforced. There are other things that happen. So I do think disaster risk reduction is a concept that if you're interested in this question, Google it and you'll get some good information.
And I only have one short comment on that. So that terminology is not really used in the U.S. much, although the rest of the world uses it. But ASPR and CDC and some other folks are part of the mitigation framework leadership group and have been able to sort of put health conversation into this discussion. So about 6 months ago, I was in a room full of feds who were saying, DRR, and they were relating it to health. So, I mean, all of this conversation is around that. We're just not using that terminology. So, just be aware that we're all working on this. And as HHS and CDC, we are in the prevention business.
Okay, well, I think we're out of time, and so we're going to close this session. So thank all the speakers for speaking earlier and for the final question.
Well, we started out at 8:30 this morning, and it is 12:30, and I think it's been a rich day here at the Centers for Disease Control and Prevention, and in our efforts to advance health equity. I wanted to just make one comment that the Office of Minority Health and Health Equity exists to strengthen CDC's capacity to protect the health, safety, and security of diverse and vulnerable populations. And we cannot achieve our purpose without the kind of collaboration that we have experienced today. And I was reminded again that we are our best when we create spaces to learn from each other and explore the difficult and arguably the impossible. But today's forum leaves me believing that building equity and community resilience in public health emergencies is a mission possible. And as a result of this meeting, Captain Wilkins, along with the planning committee, will be tasked with creating a synthesis article that will pull together the lessons learned from today that will highlight those issues that we need to bring from the invisible to the visible and actually put forward some suggestions that our colleagues both within CDC as well as in states, locales, and jurisdictions, the Caribbean, the Pacific, can glean from strategies that they can use toward advancing health equity in this area. Before we adjourn, I'd like to ask Captain Wilkins to come up. We have certificates of appreciation for all of our presenters. Please join me in giving them a hand, and I'm going to call their names. We want to thank Dr. Amy Wilkin, who I discovered today is a Tar Heel, Go Heels. I knew it was something about her when we first met her. I want to thank Mitchell Stripling. I mean, I'm just like buzzing. Thank you so much for your presentation today. And Secretary Rodriguez, we are so honored that you are here with us. We know it was a sacrifice and a huge commitment to be here, but we really appreciate it. And Captain Funk, thank you for the work that you do, for being our discussant today. Dr. Daniel Dodgen, thank you for your passion and insight and experience in the work that you're doing at ASPR. We hope we can call on you again. Dr. Karabara, who is our colleague here, who thank you for reaching out to the Office of Minority Health and Health Equity and really stimulating the development of the cultural humility training and our own Ace Julio de Saint Talapierre. He is, I consider him like one of our health ambassadors. We send him out a lot to do the kind of diplomacy that's important as we look around the globe at health inequities. And I get excited to see that we're not in this struggle alone, but that we share this space with people around the world. So thank you. Your time here. I know everybody's email screen is probably clicking off, but these are times that are very important in our own continued professional development and in our ability to push our agency forward. So thank you again, everybody. Have a good rest of the day.